Hello, once again, I'm Harper West. I'm a clinical psychologist in Michigan, and we're going to finish up our talk on clinical case formulation using a shame-informed model. And I would encourage, again, if you haven't watched the previous ones, to do so, because this is really just a summary of the other things we've talked about so far. So today we're just going to talk about the model. I've got a matrix chart here that sort of summarizes, again, the things we've talked about in a little more graphic way for use in actual clinical settings. So we've got on the left-hand side here what'll be the 5 factors that we talked about previously. And then on the right-hand side, a real specific clinical presentations of those 5 factors. And again, this is not scientifically checked. This has not been validated in any kind of way. This is just a way my brain thinks about these factors and how I see them in people. I have a whole lot of interventions and other ways that I look at this, but this is the simplest way to perceive these ideas. And the assessment pearl is that how does shame show up in this person's life, right? We're always looking for ways that shame is going to show up. And that can be confusing if you haven't used this paradigm of shame, but will help you kind of think this through. And again, unlike the DSM, a shame-informed model directly connects from these causes of shame, these 5 factors that cause hypervigilance to shame and hyperreactivity to shame, and links all the way through from case formulation then to interventions. Because if we know shame is the cause, then we know that compassion-based interventions are the solution. Compassion is the antidote to shame. It really is. Love is the antidote to disconnection, right? Shame is a disconnecting experience, and that's why it causes such emotional distress that we'll see here in this right-hand column as we go through this matrix. So if shame is the disconnecting experience, we need to teach people in therapy how to reconnect to themselves and others through love and through compassion and through self-acceptance. So the other thing that's hard, though, for people is that this is a very different paradigm from the disease model. If you've been trained and accept that there's something chemically wrong with somebody's brain or their genetics just made them anxious or depressed, it's going to be hard to look for shame. So you have to make this shift in your brain, and that can be a little different. A lot of people continue to think of these as a disease or a symptom. They're not a symptom of anything other than possibly shame. Okay. So yeah, I always dive below the behaviors. We're always going to look below the behaviors to what's causing that behavior. Okay. So we have here the first factor, which is our threat system. We all, again, if we're human, we have a threat system in our bodies. This vigilance to threat shows up in 2 main ways: hypervigilance and hypovigilance. Hypervigilance be the sympathetic nervous system, fight or flight, all the classic kind of anxiety related responses there. Hypovigilance is a downshifting of the threat system into that dorsal vagal response, submissiveness, depression, dissociation, intolerance of abuse that many people have. And then, of course, we have more balance or flexible threat vigilance. This is a healthy person who can be on guard to danger as needed. They can also downshift and be less threat-based. And then we have reactivity to threat. Same thing. Are people hyper-reactive, under-regulation, or high emotional volatility, irritability, impulsivity, sensory sensitivity, aggression, hostility, and hyperreactivity physically, or hyporeactive, overregulation of affect, flat affect, right? Dissociation, numb, depressed, checked out, under-responsive to the emotional needs of self and others, withdrawn from relationships. Or again, flexible but responding, can become active and respond and react to situations, can also calm and be settled in their responses. Second factor, fear of social exclusion, which we talked about. We can kind of divide this approval seeking or disapproval avoidance. Approval seeking, high need for reassurance, over functioning, often perfectionistic over functioning, or also narcissistic boasting and self-aggrandizement to get approval. People-pleasing behaviors is in this one. Or disapproval avoidance, avoiding making mistakes and gaining or disapproval, which can look like OCD, perfectionism, social fears and avoidance, avoidance of relationships, etc., or specific fears about being disapproved of for failures. Social mentality theory is a view of dominance or submission in others and self. We all have this as humans. We all socially rank ourselves and we all socially rank others. Ideally, though, we can have a flexible response to others. We can maybe be more of a leader in certain situations. We can also be more submissive in certain situations. The problems we have, if we have a rigid responding in social hierarchy, we may always want to dominate others so that we can control them and be abusive or coercive or manipulative in relationships. The other blamers that we talked about in the prior video as a way to tolerate shame. If a person doesn't tolerate shame well, they're going to be defensive and try and dominate others to avoid incoming shame, right? If I can dominate you and you are submissive, you won't challenge or criticize me. And that's exactly the relationship an other blamer wants. It wants a passive, submissive self-blamer to avoid sending shame and blame to the other blamer. Or we could have a rigid submissive response to others, poor boundaries, tolerance of abuse, self-blaming, self-shaming, and self-doubt, or avoidance of others. And again, flexible responding is what we really want. Shame is the third factor in our 5-factor model. We want to assess for how a person handles relationships when they feel shamed, rejected, or excluded. We talked in the prior video about these blame shifting strategies. Again, some people have a very predominant style of behaving. Others are more flexible. They might do a little other blaming and a little self-blaming or a little blame avoiding, or they might be generally pretty self-accepting and have a little bit of these other behaviors. So we want to kind of rank those and say, are they a 10 on the other blaming scale? Are they Donald Trump, right? Are they a severe narcissist, or maybe a more moderate kind of narcissistic personality, etc., right? And we want to look for the frequency and intensity of these responses. There's some other additional assessments for shame intolerance. Certainly we can just look for overt affect or body language. Are they more submissive and self-blaming? You can see that. Do they make poor eye contact? Do they have poor body postures? Easily blushing, placating, crying, nervous laughter. Incongruent emotions is one I often look for, right? That kind of always the permanent smile, even though they're saying that their pet just died, that they're smiling about it. That incongruent emotion can be a people-pleasing behavior. And obviously lack of assertiveness or passivity. Dominating behaviors, obvious narcissistic tendencies, deflecting of blame and accountability, inability to tolerate criticism is the core to look for there, and all the kind of classic antisocial behaviors. And then addictions are a clear sign of shame intolerance, because if you have an addiction, you are denying, you are not honoring the fact that you are behaving in an inappropriate or immoral way, and you're not accountable. General lack of general tendency towards irresponsibility, low functioning, inability to hold a job, frequent relationship changes, financial failures, obesity, addictions, poor decision making, all signal lack of accountability, right? If we cannot be honest with ourselves about our flaws and work to change them, we are avoiding those problems. We are in denial about those problems in a ways that signal we cannot tolerate shame. Obvious major themes of unworthiness, if people, express a lot of self-doubts, a lot of self-criticism, minor to major, body image issues, eating disorders, and again, just sort of blame avoidance, isolation, lack of close relationships, lack of long-term relationships. So that's how we can learn to look for shame in the clinical world. Acute trauma, so many things we could assess for here. The ACEs is one of the standard, easy to administer 10-question assessment. I also like to look for more psychosocial factors like discrimination on race, gender, sexual orientation, immigrant status, class, poverty, etc. Those we know create a sense of unworthiness in people who grow up having experienced those things. And I love to look for my other blaming narcissistic parents or siblings, because this, again, as we talked about before, creates this pattern of blame shifting so that the victim, who probably was a pre-existing self-blamer, has exacerbated self-blaming experiences that can be quite traumatic, quite detrimental. So really love to assess for that. That's super important to do. And then attachment style. Again, lots of ways to assess for attachment style, adult attachment inventory on down. These are two compassion-focused therapy scales, early life event scale, and early memories of warmth and safeness scale. But there are many others. You're going to come away with some sense if this person is insecurely or securely attached, and then some rating of their avoidant, anxious, or disorganized attachment patterns. So that chart is a, again, simplistic visual of it. You may add other ways to assess other ways you can look for these, but that's how I like to visualize those 5 factors and ways I look for that in sessions. So the good news is, all of these shame intolerance patterns can be so distressing to us as individuals, so distressing to our clients, but we are not born to live chronically with fear, with anxiety and self-criticism based on our shame. And that shame is a problem, but self-compassion can be a solution. It worked for me, it can work for others, and it can bring real and permanent change to us. We do not have to live with these permanent brain disorders, according to the DSM. Healthy shame tolerance, healthy self-acceptance improves the quality of the relationship with others and with ourselves. And that's why it's so healing. It heals that basic fear we have that we are unworthy, and it brings us calm contentment that we are worthy of love and acceptance because we are human. It teaches us to accept our imperfections in ways that allow us to tolerate shame in healthy ways without overreacting, without underreacting. And we can all learn these skills. I think this is what's so important. And that shame does not have to be the relationship destroyer and the destroyer of the relationship with ourselves that it is. We don't have to stay ethically bound to this DSM. I think ethically we can challenge the DSM, and we can learn different ways of relating to patients, and we can learn different interventions. These evidence-based interventions based on compassion-focused therapy and mindful self-compassion and even emotionally focused couples therapy can be so healing and helpful to people. And there's so much great research on how effective these are. As I talked about in the first video, the DSM has so many problems. We need to address this with a shame-informed case formulation model that allows us to shift the paradigm, not from disease-based, but to an emotion-based outlook, a paradigm that allows us to move into a more humanistic sense that people are just suffering with unhealthy ways of tolerating shame. So this is, what we think about, I talk about often a case here with a little guy. So many people look at bad behaviors as a diagnosis, but we can rethink this. They're not bad behaviors. There's just shame intolerance here. So thanks so much. Lots more on my website, harperwest.co. You can email me here. I've got a blog. I've got a Facebook page. For those of you who came to my class, I've got resource lists and this case formulation, and would encourage you to access those. Thanks so much for your attention to these videos, and I hope you spread the word about shame as an important emotion that we need to stop ignoring as therapists. Thanks so much, and be kind to yourself.